I have the distinct pleasure today of presenting Michael Green and Bronson Kunzler to talk with us. They put a paper out in JPSM back in June of 2023, so still very recent. The value of advanced care planning for spokespersons, of patients with advanced illness. Marty was mentioning, for those of you that maybe were here a couple of minutes ago, that this is great because we are talking same thing next week from a little different perspective. So we've got a little 2-week run here to discuss advanced care planning.
Thanks for being here, everybody. I'm glad to be here. My name is Bronson. I am PGY1 at the University of Pittsburgh in internal medicine currently. I went to medical school at Penn State in Hershey, which is where I had the pleasure of meeting Dr. Green and getting involved in this research and things like that. So I'll pass it over to Dr. Green and let him introduce himself.
Yeah, great. And I'm Michael Green. I'm a professor in the Department of Medicine and Humanities at Penn State College of Medicine. And I also chair the Hospital Ethics Committee for many years. And as Bronson said, have been doing work in the area of end-of-life decision-making for many years. I'm not a palliative care doctor. I'm a general internist by training, but I sort of come into this through the lens of bioethics and through my experience, both as a primary care doctor, but also as someone who chairs a hospital ethics committee and sees, some of the problem cases that come to us because of people's failure to engage in advanced care planning. Often those are the most difficult cases when folks haven't really talked about their wishes, and then nobody knows what to do, and the clinicians are like, all right, what should we do here? And then they come to us. So we're going to talk about this research. It was published recently, but the project is really not so new. We've been working for 15 years or more on a variety of research projects having to do with advanced care planning and end-of-life decision-making. And what we're going to talk about briefly with you here is about a piece of one of the studies that was focused on spokespersons. As I imagine most of, if not all of you know, advanced care planning has been something that has been advocated and promoted for many, many years, for decades, really, as a way of helping people think about and articulate their wishes for medical care, and hopefully as a way to assure that people get the medical care that they want and don't get the medical care that they don't want when they're no longer able to speak for themselves. And for many, many years, we've encouraged people to articulate their wishes through advanced directive forms or living wills or other kinds of formal documentation. And what's happened in recent years is that people have begun to question whether this is a good idea. So research has not consistently shown that advanced directives really work at achieving some of the goals that they were set out to achieve. In particular, helping people receive the goal concordant care that is sort of seen as the gold standard for measuring the success of advanced directives. And so the current climate of advanced directive, it fits and starts. We have conflicting opinions about the efficacy of advanced directives as a way of promoting people's receiving wishes, having their wishes followed, particularly at the end of life. A lot of the research that is done tends to focus more on the outcomes rather than the process of advanced care planning, which I think is a limitation. And there's a lot of disagreement about what outcome measures we should be looking at to say whether advanced care planning and advanced directives actually are effective or not. All that, much of the research on which these conclusions are based are small studies or methodologically challenged in such a way that it makes it difficult to make generalizations based on the various studies. And so it's a challenging climate to sort of draw sweeping generalizations about the question of whether advanced directives work or not. many years ago, by we, I mean myself and my colleague Benjamin Levi at Penn State, we thought we wanted to get into this world and develop something that was a more robust way of helping people think through the complex decision-making at the end of life. And we created a multimedia online advanced care planning program to take sort of complex decisions and break it down into a series of simpler decisions. And this computer program is called Making Your Wishes Known. And it was designed by a multidisciplinary group of folks, clinicians and geriatricians and artists and graphic designers and all sorts of different folks. And we have received a lot of grant support over the years, a couple of NIH grants and American Cancer Society grants and Greenwall Foundation. And we created this thing and we studied it at great length. And so we're going to talk about sort of one of the studies that we did with this, and actually just one part of the study. So I'm sort of setting the context, and Bronson will get into some of the details of it. But this was a study where it was originally designed to see what the impact was of this intervention on patients with advanced illness and on the people who are making decisions for them. And so what we did is we enrolled 285 patients who had advanced illness, along with the family caregiver who was their would-be surrogate. So we enrolled them as dyads. And these were patients who had expected life expectancies of less than 2 years, people with advanced kidney disease, heart disease, lung disease, and cancer. And we did the research at a couple of institutions at Penn State and Central Pennsylvania, and also in Boston, where we enrolled a higher proportion of minority patients. And this was a randomized controlled trial. It was like this 2x2 factorial design where we were comparing the Making Wishes Known intervention with standard advanced directives and also advanced care planning alone versus together. And that was sort of the big picture. What we're going to talk about today, we lumped it all together because what we're going to talk about today is what happened after people had to make decisions. And we just sort of said, all right, what was the value of advanced care planning for the surrogates after decisions needed to be made? And so very briefly, the design of the study, there were 3 visits. The first one, we administered our ACP intervention. During the second visit, we looked at the self-efficacy for the caregivers, but it was the third visit, which took place after a patient lost decision-making capacity, either through illness or through death, where a family caregiver had to actually make medical decisions on their behalf. We interviewed them, and the interviews were focused on whether and to what extent the advanced care planning experience was helpful to them and help prepare them for making decisions. And so that's what we're going to be looking at here. And so let me turn it over to Bronson, who's going to sort of talk through some of the details of the study and what we found.
Yeah, thank you, Dr. Green. So at the end of this, we realized that we had really this very large data set of qualitative data that spokespersons had shared their experience through this process. And the idea was that we wanted to see what can we learn and what can we gain from this very large data set that had been gathered through this intervention. And so what we did is we transformed the data into categorical variables and summarized it using descriptive statistics. And then as a part of that, we identified recurrent themes that we found throughout these transcripts. And then in the end once we felt there was no more themes to be identified, or we'd saturated kind of all the new themes that we were identifying, we didn't code the entire subset of data that we were working with. So to show you how the data breaks down, if we go to the next slide, as we said, there was 285 total patients in this study. 120 of those patients progressed all the way through the study, meaning at one point, because of illness or death, a surrogate decision needed to be made according to the caregiver. Of those 120 patients, or excuse me, spokespersons, unfortunately, we only had 110 usable audio files that we had transcripts from. And then we coded 51 of those transcripts until we reached that data saturation point that I had mentioned previously. And as a part of this, 5 themes emerged from our findings. So we'll talk about those primarily. So theme 1, we found that spokespersons reported multiple ways in which they found advanced directives to be helpful. And this included increasing their confidence that their decisions were aligned with the patient's, serving as a physical reminder about discussions that they had had in the past, and providing increased clarity during decision-making, particularly if there was family conflict involved. And just to share a few quotes, these come directly out of the transcripts as spoken by the caregivers. And so I'll read these briefly, bear with me. Number 1, because I had an idea of what she was thinking when her mind was clear, I was able to make a decision on her behalf with my clear mind. The second, I'll do my best to follow his wishes, and sometimes that means getting out the information, rereading it again, so I can refamiliarize myself with what he has chosen. And then lastly, I have to say, as difficult and as challenging as it was, this process helped me and made it ironically a bit easier because I knew that they were my mother's wishes, not just based on our conversation, but the fact that she had it on paper and that she had signed it. Theme 2 showed us that iterative discussions regarding advanced care planning prepared spokespersons for in-the-moment decision-making or decisions that maybe they hadn't explicitly thought out in the past. So a couple of quotes to support this. We talked to her, we had a lot of talking, and I was prepared to make a decision. I knew eventually I was going to be making a decision. And then in reference to completing the advanced directive, one spokesperson mentioned, it would not have been in the forefront of my mind to ask her, do you still want to be resuscitated or do you want dialysis? Theme 3 showed us that advanced directives and ACP conversations help spokespersons feel more prepared for future decisions, providing a sense of comfort and security. Spokespersons reported that creating an advanced directive eased the psychological weight of being a spokesperson and provided a sense of comfort knowing it represented their loved one's wishes. And in the interest of time, I only pulled one quote from here, but it says, while it doesn't help a great deal with the grieving process, it gives you a reassurance knowing that you did consider all the alternatives and that you tried to consider everything. It's important to note that, themes 4 and 5 I'll reference quickly. Not everything we found, understandably, was positive. And these are more neutral emotions or even negative emotions that caregivers felt kind of during this entire process of going through this with their loved one. So theme 4, spokespersons sometimes felt they had no choice to be made regarding one's medical care. To support this, quote 1, we didn't have a choice. The doctor said they knew it was time, and this is what we did. I mean, I just had to rely on the doctor's experience. Quote 2, I guess I sometimes wonder if I took a back seat when I should have taken a front seat, with the idea the spokesperson's feeling some regret and not really feeling like they were able to take an active role in decision making. And then lastly, theme 5, I didn't pull any quotes because I think it summarizes itself fairly well. But it said we found that the emotional experiences of spokespersons were wide-ranging, from feeling prepared and confident to being beset with anxiety related to second-guessing decisions they made. Negative emotions were regret over not having enough information to make good decisions, and self-blame for not asking more questions regarding their loved one's care, resulting in, again, second-guessing. So just to talk about a few conclusions that we drew from our paper, and I think Dr. Green set this up nicely, that we feel that these findings support the idea that we may need to pivot away from goal concordant care as the main measure of value in advanced care planning, though obviously important, not to take away from the importance of trying to go after goal concordant care, but that we may need to take a more family-centered psychosocial approach with outcomes and shared decision making. Secondly, we feel the data shows pretty powerfully that advanced directives do have inherent value for the spokespersons with regard to their psychological experience as spokespersons. And again, kind of to reference what I was saying before, while goal concordant care is no doubt important, improving this experience among spokespersons is also an important and worthy goal of advanced care planning. And then lastly, we found that spokespersons valued revisiting these advanced directives and ACP documents, and that their description of how advanced care planning serves as a foundation for their decisions provided evidence that completing this process prepared them better for in-the-moment decision-making to address the things that they did not see coming or did not actively answer or decide beforehand.
That's a good place to pause and maybe open it up to discussion, because, you know, I would very much like to hear about other people's experience with advanced care planning, and you know, whether this is persuasive as an argument for continuing value of advanced directives and advanced care planning as a process.
Sure, and I do have a question, and I'm not seeing anything in the chat or any hands up, so I'll ask mine while everybody else is putting their thoughts together. I guess the point that you made about which outcome measures we should maybe be thinking about and looking at, I very much like the idea of being able to ascertain if advanced care planning was helpful for family members, because that clearly is an important part of this. I think we all do see that we know when families when they are able to state that they have some confidence and comfort that they, you know, that they had these discussions. We all see the value of that when we're having these discussions with patients and families at the bedside. Do you have a sense, based on what you saw in those responses, of how to create an actual question or an actual metric? How would you ask that question, I guess, is where I'm going with that.
About what's the value to the surrogates of advanced care planning?
How and when would you ask it? I guess that's the question. In order to study it, you know, how do you ask it well, and when is the right time to ask if it was helpful or not? Because I think that varies.
Well, that's a great question. I mean, in the design of this study, we were looking at surrogate preparedness as an outcome, and so we had a couple of different measures of self-efficacy, like how prepared, you know, before they had to make a decision, how prepared do you think you are to serve in this role as a surrogate decision maker? And then after the fact, we asked them how prepared they thought they were to serve in this role, and, you know, was advanced care planning helpful for that process? And, you know, what we had assumed actually is that people who went through a robust advanced care planning process as a you know, a designated surrogate, that having done that would help them feel better prepared for that role. And one of the things we found is that in the quantitative data, where we used, you know, validated instruments of self-efficacy and stuff, that it didn't really play out, that they all thought they were extremely well prepared at baseline. And then after they engaged in advanced care planning, it didn't really go up. There's sort of a ceiling effect, and so it didn't go up. And the reality is that, and our, you know, my clinical experience as well, is that people say they're prepared, but they're really not. and so there's a disconnect between what people, you know, feel and they think they're prepared for this, and then what we actually see, you know, as clinicians about their lack of preparedness. And so that didn't come out. So the measures weren't great, but what we did find is that when we analyzed the interview stuff, that the qualitative data was a far more useful source of information than the quantitative data. So to sort of directly answer your question, I think we get better data about this qualitatively than quantitatively. And, you know, and so asking and talking with people and asking them and interviewing them, at least in my experience, has been more useful than trying to, you know, administer surveys, which seem to just, they measure something and it's easy to, you know, we like numbers and graphs, and stuff. I mean, I do, and certainly when you publish papers, they like that, but I'm not convinced that it's the best information about what we're trying to get at, particularly in this domain.
Yeah. Well, and qualitative data is just so much more time intensive and cumbersome to collect as well. So that does make it harder to study. I'm seeing in the chat here, Shonda Farrell is asking, did you notice frustration? Did anyone mention frustration around not having had the conversations sooner? I don't know, Bronson, if you have any specific comments on that.
Yeah, and so, you know, the limitations of writing a paper, right? You're like limited by character limits and all these other things. So there's like probably 100 more themes that we could have included in this paper. But this one in particular, actually, I can say almost did make it into the paper, if that's the right way to say it. It was quite a recurrent theme. I think the biggest frustration came from spokespersons feeling like the person they were a spokesperson for, the patient, a better way to state it, didn't want to talk about it and didn't want to address it. And a lot of frustration came from that. Them saying, you know, I remember a particular daughter-father dyad, and the daughter saying in the transcript, you know, he refuses to have these conversations with me. And for that reason, when it came time to make decisions, I wanted to hash out these things more, and I couldn't. I was unable to because, you know, he be it whether it was denial or the fact that he didn't want to deal with it. I'm not sure. So yeah, absolutely. That was a recurrent theme in the paper, and found that recurrently through the interviews with, and it almost seemed to be personality dependent, if you will. It seemed like there was a few personalities of patients that made it especially difficult for the spokesperson to address these topics. So, and I'm not sure how to overcome that, to add, you know, I'm not sure what the right answer is there. So
I think, Marty, I see that you also have a question, but Michael and Bronson, I think you had a little bit more to present, right?
So a current project that we're working on, the other one was is sort of wrapped up, is looking at a variety of conversation tools to help facilitate, get people sort of better prepared for being involved in advanced care planning. And so this is under the leadership of LJ Van Scoy, who's a critical care doctor and qualitative researcher at Penn State. And this is called Project Talk. And it's looking at these 3 different conversation tools, one by the Conversation Project, the other a game called Hello, which is an end-of-life conversation game. And the third is our control group, which is Table Topics, which is kind of a general conversation game. And we're looking at whether these tools impact advanced care planning rates and the quality of the conversations, and particularly focusing on underserved populations. And it's a big study. It's a national sample where we're recruiting like 75 hosts game across the country. And we've done like 53 out of the 75. And this just sort of shows where we've done it so far. And the reason and people say nice things about it, the people who are hosting the project and the participants. And the reason I'm just telling you about this is that we're always looking for additional hosts. And if there's people, you know, in this call or watching this, and you are interested in getting involved by perhaps hosting a conversation-based event in your community, it's really easy to get involved. And I put this little QR code reader thing here. And if you're interested, you just point your camera at that and it'll pull up a website that has an application process and more description about what this study is about. I would say it's really, well, it was surprising to me how fun it is, because I thought when I first got involved with this that, you know, people would sort of not think it's fun to talk about, you know, death and dying, but people, strangers, all sorts of different communities, people play this game and they really enjoy it and they learn a lot, and the results are pretty good in terms of using this as a stimulation for further advanced care planning behaviors. So that's just a little pitch for if you want to get involved in this sort of thing.
Thanks for sharing that. Maybe I'll see, I did take a picture of it. I'll see if I can type it in the screen, but it'll also be on the recording, the web page itself. Marty, did you want to ask your question now?
Yeah, perfect. Michael, Bronson, thank you. We really appreciate your time today. I have been thinking about how some hospitals have been kind of pushing advanced care planning for a variety of reasons. And sometimes some hospitals even have departments, committees all about this. And I assume that part of it was because of the original hope for outcomes, right? That it was goal concordant care, but also it was hoping that it would decrease healthcare costs at the end, right? There's a practical incentive as well, which didn't seem to pan out, at least so far. How are you using this information to talk to hospitals about this benefit? How are you trying to sell this to hospitals? How can they incorporate some of this?
Yeah. Well, so I remain advocate for robust advanced care planning. I think it's helpful for patients. I think it's helpful for surrogates. I'm not really big on the check the box kind of advanced care planning, like, yeah, let's do this and fill out this form and check the box, just to say that we did it because it looks good on our metrics or whatever. And I think the truth is that there's, the quality of advanced care planning is really mixed. And, as a primary care doc, I've had many experiences with patients who come to me and they hand me their living will document that they filled out with their lawyer or on their own. And when we actually talk about it, like, what are your goals and what's really important to you and what really matters to you, it's not really reflected in the document because they just filled it out without really thinking about it or without thinking it through, in the way that someone who has experiences in these, kind of discussions and realities would think it through. And so, I mean, I'm a big fan of doing good advanced care planning. I'm not a big fan of just pushing advanced directive completion rate for the sake of completing advanced directives, because I think that it doesn't always work, especially if it's not a accurate reflection of what people care about the most. And so, the palliative care world, you guys are great. I mean, you talk to people and you do goals of care conversations and you sort of try to unearth what really matters to people at the end. And I think that's really important and probably more important. You got to document it, but it's more important than sort of let's just boost our advanced directive form completion rate, because I don't know what that means. I mean, a hospital says, yeah, 80% of our patients have a living will. Okay, so what? I mean, are they good? Who filled them out? What was the conversation about that led to the complete, these post forms? And we see these all the time, but it's like, who filled it out? And that should have been the end result of a really robust conversation, not the end in itself. And sometimes I see these things being conflated with one another. And so I don't know. I mean, you all know this stuff says it's complex. It's not simple.
Yeah. Even the opposite. Sometimes I see I'll read an advanced directive and there'll be something written and it'll be 3 words and it'll be so confusing. What in the heck do those 3 words actually mean? And how sometimes it almost adds to the confusion.
Mm-hmm.
Yeah. But I think what our data show is that, when people really do engage seriously with these conversations and discussions, that they find it valuable. It's reassuring that, for the surrogate that, that they really understand what the patient wanted, I think it helps the patients to know that somebody's listening to them and cares about them and cares what they want. And, and I think, it's more about conversations than it is about filling out the forms, and that takes time, and it takes some difficult and challenging kinds of discussions that sometimes people are ready for and sometimes they're not. So there's no, I don't know, I don't see shortcuts for this.
I think that's an excellent note to end on, because we're at about time. I'm not seeing anything else in the chat. So yeah, Bronson and Michael, thank you so very much for joining us today. This is a great discussion. We're grateful to have you. I did post that in the chat. So if anybody's interested in seeing about doing that project talk,
Great.
so awesome. Well, thank you all so much. Everybody have a great weekend, and we'll see you all next week.
Thank you so much for the opportunity to talk with you.
Thank you all.
Bye, everyone.